Hello, and welcome to this touch-in conversation activity. My name is Dr. Carolyn Clevenger. I'm a professor of nursing and a gerontological nurse practitioner at the Nell Hodson Woodruff School of Nursing at Emory University in Atlanta, Georgia, in the USA. And I'm the founder and director of a practice called Integrated Memory Care. I'm delighted to be joined today by Ms. Kathy Ryan, a family caregiver for her husband, Bill, and who I know from our IMC practice and who is one of our family advisors. Today, we'll be discussing agitation in Alzheimer's dementia with a focus on understanding its prevalence, symptoms, and how to diagnose it. In this first session, we'll be considering the prevalence of agitation in Alzheimer's dementia and how it can vary with disease severity and setting. Alzheimer's dementia is in and of itself a common and increasingly prevalent condition worldwide, and one of the most common symptoms that comes along with that is agitation. We think about Alzheimer's disease or Alzheimer's dementia in 4 stages generally. I know there are a number of staging tools that people use. I often think of it as mild or early, mild moderate, moderate to severe, or severe. Very commonly, agitation appears by the time someone is in that moderate stage. Agitation is absolutely as common or nearly as common as memory loss in Alzheimer's. And so if someone has not experienced or expressed symptoms of agitation in that mild or early stage, most certainly they are doing so by the moderate stage. In fact, it is one of the most common reasons people seek our practice. And agitation is slightly more common for people residing in long-term care facilities when you compare them to folks who are community dwelling or in their homes. One of the reasons and drivers of placement in an institution or a long-term care setting is agitation as a symptom. And so it's not surprising that it is slightly more prevalent in that setting as opposed to people's homes. So, Kathy, thanks for talking with me today and sharing about your family's experience. Agitation is really challenging, probably one of the most challenging symptoms in dementia, and healthcare professionals are not necessarily aware. They have trouble identifying the symptom, but we have a number of attendees today who are interested in learning more, which is good news. Mm-hmm. So let's discuss some questions that have been submitted by our audience about the prevalence of agitation in Alzheimer's dementia.
So exactly what is an agitation episode, and do all these episodes need to be reported and professionally reviewed?
So agitation falls into these 3 buckets. One is excess motor activity. So somebody looks like they're rummaging, they're pacing, they're going through closets. And then it could be verbal aggression. So saying, accusatory things, maybe yelling. It can then also include verbal aggression, and that includes pinching, biting, kicking, throwing things, or striking someone. So they may happen one time, and I think sometimes that's when I hear about it, right? We had this one episode, and it's a call maybe to the clinic or it's something, but it tends to also creep up, right? It may begin with being restless and just sort of pacing, and then it works its way up to more aggressive behaviors, which can lead to a healthcare encounter, hopefully not an emergency department kind of encounter. So for me as a healthcare professional, it's just helpful to have that episode described to me. And if there's a pattern, that's really meaningful. And so some people journal about their experience anyway, or they're just tracking these types of things. I don't necessarily need them to interpret or diagnose for me, but if they can paint a picture, sometimes I'll ask that, like paint a picture for me. If you were describing a film, what happened? And I certainly want to know if there are concerns about their safety or about their person's safety. And we want to talk about a safety plan if we're really concerned about that. I want to know if this happens most often in the mornings or if it happens during the night. I want to know what else was going on. This is a symptom. And so we ask things like, when did it start and what makes it better and what makes it worse? And have you tried anything to treat it? And in agitation, I also want to know, do you have any help or support helping you manage this symptom? Because the stage of the game, it's a clear sign that maybe we need some additional help besides just one person if it's only been one caregiver.
So what triggers or causes this agitation episode from your perspective?
So there is a physiologic reason for agitation. It's an imbalance of these three chemicals in the brain: serotonin, norepinephrine, and dopamine. And in some cases, they're overproduced or underproduced. In some cases, they're just too active in the wrong part of the brain. So it creates a lot of excitability in our emotional center of the brain, and that's combined with less inhibition. So there's a physiologic reason. It's not always an environmental trigger, but many times an environment or people or an activity, something can trigger it. It can be unpredictable too. So what I often say is this person has sort of less ability to cope with the everyday stresses, something that may have been able to easily cope with. We would say just rolls off their back. Now that happens and it causes an explosive episode and furiousness. And so it can be hard to really know. It is helpful if you have an idea of what commonly triggers it, but I want caregivers to know that just because they did something that then triggered this agitation episode, it's not their fault. They did not solely trigger this. This is part of a disease, and there are brain changes that can do that. Sometimes it's really stressful because the triggering event or triggering object is you. It can be the person or somebody else in their life. It can be an activity. It can be something else going on with them, like physically. So some things can trigger, can cause it. It's not always a trigger. It just also happens.
So what is the prevalence among people that are living with dementia? What's the prevalence of this agitation?
I think most people are surprised to know this is very common. Something like 85 to 90% of people with Alzheimer's dementia will experience agitation at some point.
Wow. So how does prevalence vary with the severity of the individual's dementia, or with if they have underlying medical conditions? What happens with that?
So certainly most people experience agitation in the moderate stage of Alzheimer's dementia. People can experience it earlier, and maybe that's related to underlying medical conditions for that person. Because in Alzheimer's disease, most people are older, they're more likely to have other chronic conditions and health problems. So we typically think of it as a later stage sort of symptom. Things that might increase the frequency of agitation episodes or might lead to agitation sooner can be really any physical condition that makes you not feel like yourself. All of us have a shorter fuse on a day when we didn't sleep well. And maybe you're not sleeping well because you've got arthritis pain or gout pain. Or maybe it's because you have sleep apnea that now you don't want to wear a mask for. Or your enlarged prostate is causing you to get up multiple times during the night. But you might not feel well because your blood sugar is too high or too low, or your thyroid balance is off. And so really any other underlying medical condition that's causing stress, physiologic stress or emotional stress on you is probably going to increase that expression of the agitation symptom.
So how does the prevalence of agitation vary with the setting that the person is living with dementia?
So agitation is a bit more common in a residential care setting. And so any long-term care facility, and I would include in that assisted living, personal care, memory care, and nursing home. Now, there's a good reason for that, because people who are experiencing agitation that is just really difficult to manage, and as the disease progresses, that tends to lead to, or that might prompt the move to a long-term care setting. That would be very common. So we would expect people in that setting to have more of that symptom because that's what brought them to that setting. It's also true that the care environment around you matters, and most people are comfortable at home more so than in an institutional setting. And I know so much work is done in the institutional care, residential care world, trying to make that setting more home-like. But it really is difficult because there's no place like home.
Right.
And at a minimum, you will see different staff during the day. And so there are a lot of people who have turnover, and that, of course, doesn't speak to just staff turnover in general, which we also know is relatively high. And so you'll see more of it in that setting.
So what are the implications for early identification and management?
I will say clinically, I get different reports from the residential care setting or long-term care than I do from families. And it requires some sensitivity to interpret.
Ah, that makes sense.
Yeah. So in the nursing home world for a long time, we would get messages about the patient's agitated, and agitation could mean literally anything.
Not
Right.
helpful.
It's just a really common term that people throw around. And I used to get really nervous that we're over labeling people agitation. And so I was trained in my nurse practitioner training to ask, paint me the picture. What does that look like? Tell me what that means to you. And it turns out that's helpful when you're talking to families who are dealing with their person at home. They may start with the picture. He's pacing at 4 o'clock every afternoon. He's been really difficult, and what does that mean? So if they're describing often the behavior itself, although sometimes they describe how they've interpreted the behavior, and because families have a different relationship than a professional or staff caregiver might have, sometimes families interpret that as being caused by something they either did or didn't do in their caregiving. So they might say, I'm coming in today because they're anxious. Well, how do you know that they're anxious? Are they saying it? Are they doing things? And then they start to describe behaviors that I now recognize as agitation. So it's a different investigative work on both sides because the language is really different from each side. But in either case, it's of course falls to us as healthcare providers to know when the symptom is experienced, when someone's expressing it, so that we can make that part of the treatment plan. Our second educational module will focus on the impact of agitation and Alzheimer's dementia on patients and care partners. Agitation has 3 domains as defined by the International Psychogeriatric Association. They include excess motor activity that might look like restlessness, pacing, rummaging. It's verbal aggression, which might be cursing, yelling. It would include physical aggression as well, from pinching, biting, striking someone, or throwing objects. As you can imagine, these are challenging symptoms, and they affect both the care partner or caregivers around the person, and they affect the person who's experiencing these symptoms as well. Often we think about the safety and the emotional stability and support we put around our family caregivers or care partners, because it is primarily these symptoms that drive that increase in caregiver stress, depression. They have distress related to the symptoms and that need, again, for additional emotional support. All of this tends to reduce their quality of life. It reduces their ability to be productive in their own lives, whether they're still employed or they have other responsibilities, which of course then leads to loss of income. For patients who are experiencing this, there are also physiologic changes and worsening in their symptoms and their disease process overall. We see more rapid disease progression or decline. We see more deterioration in their health, both their physical and mental health, and they have more functional decline. And that is both because of the biological changes that are happening with untreated agitation, and it is because they are unable to accept help and assistance from others to complete those activities of daily living. All of this increases the cost and the time that caregivers have to spend to support this person. It often leads to use of medications in addition to caregiver non-medication therapies that we put around the person, and it is the leading cause of institutional placement in long-term care facilities. Overall, people experiencing dementia with agitation do have a reduced quality of life for themselves as well as for their care partners. Agitation is one of the leading causes that prompts patients and families to find my practice, Integrated Memory Care. I want to tell you a bit about this practice model that we've created. Overall, the goal was to create a one-stop shop, one practice that reduces the fragmentation in which patients and caregivers were going to multiple sources and multiple locations. Family caregivers told us that what they really needed was to have all of their care under one practice, if at all possible. And so our goal ultimately is to improve their quality of life and the quality of care for the person with dementia and for their family caregivers or care partners. So we've placed a number of specialties that are typically in separate practices, all under our one roof, with geriatric primary care, that dementia specialty or cognitive neurology specialty, geriatric psychiatry on the team, as well as caregiver services and supports like educational classes and groups and psychotherapy. We've really found it to be a very powerful thing to make sure that these services are provided for patients and their families with dementia, and that they're done in one place seems to make a tremendous impact on their quality of life, just like we designed. Kathy, healthcare professionals like me play an important role in the identification and treatment of agitation, but they're not the most affected by the symptom. People living with dementia and their care partners experience it 24/7. They have the most exposure to agitation, and subsequently, they experience the consequences. So let's discuss some questions that have been submitted by our audience about the impact of agitation in Alzheimer's disease on patients and caregivers. What are the key signs and symptoms of agitation, and how do healthcare professionals like me discuss them more effectively with caregivers so that we help them identify and understand them?
Well, what I have found is that there's lots of different indicators of agitation. Sometimes it's just very subtle. They just start feeling uncomfortable and moving around or fussing with stuff. They're not nice and calm and peaceful. Sometimes it just escalates right away and they just take off when you're on a walk, and a lot of things in between. And sometimes it can just explode out of nowhere. You can be helping them get dressed and all of a sudden they whack you. So it's all different kinds that they do that. And so I think it's really important for healthcare providers to understand the emotional state of the caregiver when they come into the office who's experienced this agitation. Mm-hmm. It's very upsetting. Emotionally, they may be feeling like they're doing something wrong, or that their person doesn't love them anymore. It's a personal attack on them. There's just so many really strong emotions. So they're coming into the office very stressed out, very emotional. So as a healthcare provider, you need to meet them there, and you need to try to talk with them and empathize with what they're feeling, to empathize with that, support it, and allow them to share a little bit about how they're feeling and tell them, this is natural, I understand why you'd feel that way, and then begin to educate them about the disease and how it's the disease and not them. But you have to meet them in that emotional place and be sensitive to that.
Absolutely makes sense. What are some of the key impacts of agitation on people living with Alzheimer's dementia, and how can caregivers or care partners manage them in the short term?
Well, two things come to mind for me. The most primary one is the safety issue, the safety of the patient, because so many things they do they can hurt themselves. The safety of the caregiver, the care partner, and then if there is another person who's helping, those folks as well. And in the case of my husband, he would take off down the street, so there were many potential people that could be affected by his agitation. I also think it has a huge impact on the patient and the caregivers and care partners' peace and well-being. It's just so difficult to live with that for all of them. Yeah.
Tell me how caregivers or care partners can help manage those symptoms in the short term.
One of the things that I found is that it was really important to join his world and to understand where he was coming from. And so typically he was in some emotional state when it would happen. Mm-hmm. He might have been really angry, he might have been frustrated, fearful, trying to identify what was the emotion that was behind it and empathize with it. And so I'll give you an example. We were in the emergency room and he was waiting to get a CAT scan. And all of a sudden, he got very upset and very anxious and said, "We have to go home. There's a raid at the house. We have to go home." And so instead of telling there's not a raid, I would say, "Oh my gosh, I can see why that would upset you. That's really disturbing. Oh my goodness, that's scary." And then say, "Well," and this is what I said at the time, "but I know that the police are now there. They've arrived, they've responded to the raid. So it's dangerous to go there right now. We are safe being here. We're much safer being here. So let's just stay here for now." We used a lot of improvisational skills in our training, and it's invaluable. You need to remain calm. Remember that you and your face and everything you're doing is a mirror to the patient. And if you are upset and angry, they're going to mirror that right back, and you're just going to escalate each other. So despite how hard it is, you have to remain the calm, non-anxious presence, and then later go drive in your car and scream. That's what I tried to do. Don't meet fire with fire. Be patient and loving. We had a situation where we introduced a caregiver the first time into the family room, and he barricaded himself against the doors and stood there and would not move. and we waited for 2 hours. You had to be very patient. At some point, we thought we could bring a chair up so he could sit down, and he sat down. And we just tried to make the most calm environment and just waited until it came through. But this was a big change to his environment. We also found it was important to keep just 1 or 2 people in the room. Too many people was very disturbing for him. A predictable routine, and then just pay attention. Watch for the things that are stimulating, and try to respond to those, and be prepared to make changes in his routine. We used to take daily walks, and over time, we had to keep adapting what we were doing till it got to a point one time where he just ran up someone's driveway, laid in the leaves in the yard, wouldn't get up, and I had to sit with him for 30 minutes so I could get him, so that was the end of the walks then, okay? So I tried to honor and validate his feelings, divert him when I could to a calming activity. In his case, the Sound of Music video always calmed him down. Notice specifically what is making him uncomfortable. So just like a pediatrician would do with the baby, is it sound? Is it temperature? Is it his clothing is uncomfortable? Is he hungry? Is there pain anywhere? Any way you can figure out what might be causing it, because oftentimes you just solve that and then he would be calm.
Kathy, I hear so much about your flexibility, your investigation, and a little bit of performance art in there as well. And so hopefully those are some of the things that you bring, obviously, to this role, but also the classes and some of the trainings that we've done at Integrated Memory Care. Improv is often a favorite.
Oh, absolutely. Yeah. It just happened that I had some background, and my daughter definitely had training in it. So we had a little bit of an advantage that way.
So what do you think are the key aspects for people living with dementia and their caregivers to understand about agitation so they can support us, nurse practitioners, physicians, and other healthcare professionals in managing the condition effectively?
I think it's very easy as a caregiver to think that somehow you have failed as a caregiver, that this is your fault, it's something you're doing or not doing. So it's really important for the healthcare provider to help the person understand this is the disease, this is not you, there's much that you cannot control, and also to help understand, what are the things that might have an influence that you have some control over, and to really understand where that caregiver is emotionally, because it's so painful to be attacked by this person that has loved you. I can't even describe what that's like. It's very scary and very painful emotionally. So meet them at the emotion. I think it's extremely important to encourage the care partner to share all the specific experiences they're having. And the only way they're going to be comfortable usually doing that is not in the same room as their person. It's too embarrassing, and then they're going to get all kinds of grief back. And my husband always denied that he had dementia, so it's ugly. So if you can give their permission to write you a letter in advance and give it to the nurse, or send a note in my chart, or meet individually, especially the very first time you're working with someone, to have a one-on-one meeting with someone would be the ideal, absolute ideal if you can.
Yeah, I would imagine if someone is denying that they have dementia, they're certainly not open to discussing their other symptoms that you're seeing.
Going to spend the whole time with them, giving the rationale why this doesn't mean that they have dementia.
Of course. So what are some of the key impacts of agitation on the caregiver, and what can I do to support them in better caring for their person who has dementia and is also experiencing episodes of agitation?
So for me as a care partner, it was so unpredictable. It was so explosive. It was like living with the potential for an earthquake in any moment, or the aftershocks of an earthquake. And now you've experienced it. Now you know it's going to happen, but you don't know when. And so you live in this constant state of hypervigilance. It can feel very much like a personal attack. And the scary part for me was the threat to my safety and the safety of others, including his safety. I mean, that really added tremendously to my stress. I felt tremendous responsibility to all of us to try to keep us safe.
So I imagine living in that constant state of stress probably has long-term impacts for people. And I don't know if you can speak to sort of how that's been for you. And I know you talk with other caregivers who've had similar situations.
Yeah, it has a it has a huge impact. You have to work really hard not to get extremely depressed or not to do unhealthy coping behaviors, which, I certainly had my share and the other caregivers do as well. So it's just a Herculean task, and it's not for a short period of time. My husband had Alzheimer's for 15 years. So you're doing what I'm talking about for 15 years. And the longevity of it and the requirement for resilience in that environment is enormous. Yeah. Ways you could help the caregiver, I think helping them understand and accept that this is part of the disease, this behavior is part of the disease and not how they feel about you. That's really important. It is their emotions and how they feel about their environment that's the root cause of what's going on, and also whatever is happening in their brain. Help us as care partners to understand what the triggers could be, educate us on possibilities so we can be good detectives, what's happening in the patient and strategies to address those. Help us express and acknowledge our grief. There are so many losses that come with being a care partner. It's unbelievable, all the ways that your life changes, all the things that you lose, and to be able to acknowledge and support that grief is very important. Teach how to express and honor your emotions. That's one thing that became really important for me, was to learn not to stuff it, not to try to just move on, but take time to really feel this emotion deeply and let it do its work with you, and then move on. And that takes some training, I think. Counseling support, having a professional facilitate the support groups, because I've been in both kinds and that works so much better. Physical exercise became really important for me to release the stress. If the person can get a massage, but learning breathing techniques, having friends to call, meditation, faith practices, these were all the things that I used to help me get through. But, even with all of it, everything I did, in the last year and a half, I placed him in a personal care home. Even though I had in-home support, I just emotionally could not do it anymore. It was just, I was going down the drain, is the way I would talk about it. And no matter, I did all of these things on a regular basis. I was very disciplined about it, but it's so enormous to live with this 24/7. So even if there's a caregiver in the other room taking care of everything, you are still aware, hypervigilant, supporting that caregiver. It's affecting your sleep. I can't even tell you what it's really like, and for that long. And so everybody, typically hits a wall. And when I'd sit in support groups, I could see when people were going down the drain. And we would encourage each other. It's time. They can't, everybody, we all have limits and everybody reaches them at different times. But to help encourage the caregiver to grace those limits is important.
Kathy, I can't thank you enough for sharing and being vulnerable about this really challenging experience that your family has had and has managed for a long time.
Yes.
So that others can learn from your experience.
You're welcome.
For our third educational module, we'll talk about how to recognize and diagnose early stage agitation associated with Alzheimer's dementia. Agitation has this expert definition defined by the International Psychogeriatric Association, or IPA. And there's also this helpful decision tree for clinicians in terms of how to apply this to your clinical practice. The decision tree begins first with the clinician asking the question as part of their interview whether there are any behaviors that the person's caregiver or the person themselves are concerned about, or that make caring for their person more challenging. So remembering to ask that question, quite helpful. Optionally, you can quantify that. So how frequently is that happening? How severe is that behavior? And there are some ways to do that with some validated tools we'll talk about in just a moment. And then this is a symptom. And so when it's present, we'll want to understand more about that symptom, as well as understand what differentials may be in place to consider. So we're assessing for delirium, or that acute confusional state with loss of attention. We want to know whether pain in and of itself is causing these symptoms or behaviors, Not that it can't co-occur with agitation. Same is true for depression if depressive symptoms are inadequately managed. If there is also psychosis present with hallucinations, paranoia, or delusions, we want to make sure those are treated effectively, as well as environmental factors that may be able to be addressed. And so if we've identified any of those underlying causes or conditions, we certainly want to treat those. That does not mean it's exclusively separate from managing the agitation, but you would determine then if this person does meet those IPA criteria. If they don't, continue to monitor. As we discussed, as Alzheimer's dementia progresses, that symptom is very likely to appear at some point. If they do meet those criteria today, you would begin your treatment plan with non-pharmacologic approaches, which include all manner of interventions, most of which, frankly, will require the caregiver or care partner to understand. Many times that's who's implementing those approaches. And so we might refer them to support groups in your community if your practice doesn't offer them, psychoeducational programs, books, podcasts. I always say whatever resource that care partner is able to take advantage of and is willing to, I want them to have a good recommendation from their clinical team. And then many times this is not necessarily an either or, it is both and. Both non-pharmacologic and pharmacologic management is often also required, especially if there's no improvement or it's worsening, or if it simply is still not safe or well tolerated for the patient and their care partner. You do have tools that exist today to assess agitation beyond that clinical question. They are typically not created for clinical practice. Many of them are more suited to a research environment. That's true for the agitation and behavioral mapping instrument, your behavioral activity rating scale, Cohen-Mansfield, I think most of us are more familiar with, and the modified overt aggression scale. These are more specific to agitation themselves, but again, I find them not the most smooth for our practice. At our practice, we use the neuropsychiatric inventory, which gives us a broad understanding of someone's neuropsychiatric symptoms, not necessarily then specific to agitation, and that's similar for some of these other tools that you see here. The value, though, of using a tool is that it's a validated instrument. Some of them have an interpretation or scoring guide, which may also prompt you and your clinical team to understand severity. But if they can be done and in place, it does create a reliability beyond counting on ourselves as the clinician during the interview to ask that key question. Let's discuss some questions that were submitted by our audience about how to recognize and diagnose this early stage agitation in Alzheimer's dementia. Let's start with some of the key challenges to identify an agitation episode from both the caregiver or care partner and also from the clinician perspective. I'll let you start with the caregiver and care partner perspective.
Well, in the early stages, it's really hard because typically as a care partner, you still think you're in your normal relationship with your spouse, and so everything's going through that filter. Mm-hmm. And so initially, when they do what they do, it's like, you have such a temper. Why are you so grumpy today? Go sit in your grumpy corner. You're just not thinking at all about a disease. You're reacting as if you're just having a fight as a couple, and that's where you go. So being able to have this care partner describe what's happening, but getting them to see that actually there's other factors that are leading to that is the switch that needs to happen. So the care partner might not be able to even present it or talk about it, or they may just say he's just been difficult to live with. Mm-hmm. That's it. You're not going to get any details. Mm-hmm.
Yeah, I think from the clinician's perspective, mm-hmm. We're just not necessarily thinking about this as a symptom. We think about people with Alzheimer's dementia as being forgetful and needing some help in those domains. And unless somebody says, I've had a huge crisis or this is happening, it really sort of gets missed. And I think also because it can be like this is an interpersonal issue, mm-hmm. It sort of gets a little bit uncomfortable, right? I mean, if you're, a classic training is like, this is a symptom from this pathology, and then here is the treatment. And so this gets nuanced, it sounds mm-hmm. like, probably the way you're describing it early on.
Yes, yes.
So then what are some of the strategies that clinicians, healthcare professionals could employ to support recognizing the symptom earlier?
Well, I think I have found it most helpful when I've gone to clinicians who have some kind of form that I can fill out with very specific questions, because I might not think about it as something to report, but if there's prompts that will allow me to think about what's been happening and I can answer as if I'm not capable of recognize it myself. The other thing that I thought of that's important is that the clinician anticipate issues. So I'll tell you a difficult story about a clinician, and that is it was clear that I needed to not have my husband drive anymore, but and he was tested, but the doctor was very uncomfortable telling him that he couldn't drive. He said every time he does that, then the patient's mad at him and doesn't work with him. So basically just put it right in my lap. So one of the really difficult agitation situations was when I had to tell him he could not drive anymore. And because the memory was bad, I had to keep repeating the same episode over and over again. It was extremely painful. And so as a clinician, to anticipate the things that might cause agitation and support the care partner and not just lay it all on them.
I think, though, there's that anticipatory guidance piece,
Yes.
is sort of knowing what's coming.
Yeah.
We think about that a lot at integrated memory care,
Right,
of course.
Exactly.
But then there's also value to asking these questions early. That
Yeah.
plants a seed. So asking a question actually teaches people things. So
Yes.
early on in Alzheimer's especially, you probably asked questions about memory and visual spatial ability and word finding or language difficulties. We ask about function, like driving. I think even asking questions like managing medicines. So if I ask somebody, are they taking their medication, what we say, regularly or reliably?
Mm-hmm. Mm-hmm.
And maybe the person who's with them is like, yeah, I think they are. I'm like, well, how do you know? Like, I don't know. How do I know? Right? I planted the seed and now they're paying attention to their medicine. So if I ask the question, are they pacing? Are they restless? Have they been rummaging? Are they packing up their bags to leave? Those plant the seed. Maybe that's not happening today, but when it does happen,
Absolutely.
then they're like, oh, there it is.
I remember that.
They asked me about this. I had
Yeah.
a sense this might happen or that
Yeah.
it would happen. Yeah.
Yeah.
So that's definitely a better strategy, I think, than just relying on people to say, I'm having a huge crisis.
Right.
Things have really fallen apart and now we're in the hospital or in the emergency department or for a psychiatric placement.
Right. So another one of the questions is, what are some of the strengths and limitations of key strategies used to assess for and diagnose agitation, and how can these strategies be optimized to facilitate an earlier diagnosis?
So the worst strategy is waiting for the crisis to happen, right? We would really I feel like a lot of my job is to avoid or reduce crises as they occur. So that would be the worst. So ideally then you would want to assess when something is happening. We want to assess and diagnose when something occurs. And if it's possible, prevent, right? That would sort of the ideal thing. So, I think some of the tools that I mentioned previously are really helpful. These are well-validated tools. They capture a range of symptoms. Sometimes they capture frequency and severity, but also the distress related to those symptoms. So that tells me a little bit about the person and about their care partner and what both of you may be experiencing. But they're a little bit onerous. So the way that we do this, and I think is most helpful, is if you're using that validated tool, it's part of the pre-visit check-in. It's sort of a consistently done. We're just not waiting for something to be the problem. We're asking ahead of time. So we might say in the quality measures, you should be assessing for psychiatric symptoms every 6 months. So you can put that on a schedule. Now, probably the ideal is to use something like a screening tool that has, fewer than 10 questions. Someone can answer those yes, no, and at least it prompts the clinician to know, now I need to do more digging, so more investigative work. So tell me more about this. What does it look like? When did it start? What makes it better?
But it also gets me thinking as the care partner, with those questions, me would start reflecting on what I've been experiencing.
Yeah, I think, so then we catch it early, right? So I've planted that seed with you, something occurs and you kind of know this is part of the disease.
Right.
Which I would imagine helps stigma too, because we've said this is part of the symptom package.
Right.
And then when it is happening, I catch it maybe while it's still on the way up, right? So those symptoms of restless behavior all the way through physical aggression, they escalate theoretically in that order, most commonly. And so I'd really like to get someone back at the restless behavior stage, not when we're like off the chain at the very physically aggressive.
Because I've definitely seen other care partners be really embarrassed by what their person is doing and really try to minimize it. And so that may be keeping information from being shared as well.
Yeah. But if we don't ask the questions consistently,
right,
we get it.
So what role does early diagnosis play in limiting the impacts of agitation on people living with Alzheimer's disease?
Well, the first idea is, again, preventing the crisis.
Mm-hmm.
So we want to catch people on the way up, right?
Mm-hmm.
It's if you think about it, if you're a clinician, we're trained to think about managing pain in a similar way, right? We don't let it get out of hand.
Right.
We get ahead of it.
Yeah.
So if you think about agitation in that same vein, can we prevent a crisis from happening if we address it while we're still at that restless behavior stage? You know, the other thing about sort of preventing more of the symptom, or at least managing the symptom better, and that may include training people around them to help manage the symptom better, is maybe we can reduce some of that distress. Maybe we can reduce some of that strain. This may be also part of delaying disease progression, which is a huge component of Alzheimer's disease management, is about delaying how quickly the disease progresses. Agitation causes more rapid decline. Mm. So, and then I think it's important to keep in mind that, this may delay or may avoid an institutionalization. It won't always be able to avoid, certainly, but even if you're able to delay, there are so many benefits that may be a source of strain and stress emotionally and financially for families if you can delay that placement. And so getting management and therapies on board early on improves quality of life for everyone in so many different ways. Mm-hmm. Kathy, thank you so much for spending this time with me, for having this conversation. I'm so fortunate to have known you and Bill, and so fortunate to have you as a family advisor for our practice. Many healthcare professionals never get to hear the full story and this side from our family care partners who are experiencing these symptoms and so many others. So I just want to say thank you from myself and from all of our learners.
You're very welcome. It means the world to me to help make a difference for other folks that are going through this.
I know it does.